Welcome to Looking Ahead, Hospital at Home Beyond the Public Health Emergency, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine and the American Hospital Association. We'd like to recognize the generous support of the John A. Hartford Foundation for the Users Group and for this webinar series. It's now my pleasure to introduce our moderator for today's webinar, Dr. Al Su, a member of the Hospital at Home Users Group leadership team. Dr. Su has been a national leader of the Hospital at Home movement in the United States during the last decade. And today he is director of Mount Sinai at Home and a professor and chair emeritus of the Brookdale Department of Geriatrics and Palliative Care at the Icahn School of Medicine at Mount Sinai. He also holds an appointment at the Geriatric Research Education Clinical Center, GREC, at the James J. Peters Veterans Affairs Medical Center, which has its own Hospital at Home program. Please take it away, Dr. Su.
Thank you, John. And thank you and welcome everybody, for attending our webinar today. I'd like to welcome you on behalf of the Hospital at Home Users Group, led by Bruce Leff, David Levine, Linda DeSherry, and me. I understand that we had, at least as of a few minutes ago, over 374 registrants for today's webinar, and we welcome you, to stimulating our discussion. Before we start with today's webinar, I want to take this opportunity to introduce Ronnie Snyder. Ronnie is Vice President for Programs of the John A. Hartford Foundation. John A. Hartford Foundation has been a long supporter of Hospital at Home, the Users Group, as well as many other programs to improve the healthcare experience for older persons in this country. Ronnie herself has had deep experience in healthcare and aging services and in philanthropy.
Thanks so much, Al. It's great to see you. For those of you who I don't already know, just to let you know a little bit about the John A. Hartford Foundation, our mission is to improve the care of older adults. And so the work that we're here to talk about today is very much in line with our mission and with our three program areas, which include building age-friendly health systems, supporting family caregivers, and improving serious illness and end-of-life care. The John A. Hartford Foundation, with our mission and these three programmatic areas of emphasis, really believes in this hospital at home model. We've supported it for many years. We've supported Al, and we've supported Bruce, and we've supported the full team. And so are really thrilled that you're here today for this users group as well. In fact, I personally support this so much that I recently co-wrote a health affairs blog in support of Hospital at Home with recommendations that are specific to how to incorporate and train family caregivers with regard to Hospital at Home. So part of the reason that we so strongly believe in this work is that we really endorse and enthusiastically support this team. The folks who have been doing this work for a long time have so much experience and wisdom and have been so generous in sharing that, which is part of what this users group is for all of you, for all of us. So we want this model to be available, given the proven value that it has. We're so thrilled with the work that's being done to educate all of us and to educate policymakers about the model. So just a warm welcome from the John A. Hartford Foundation and a huge statement of our enthusiasm and support for this group and all of your work. Back to you, Al.
Thank you, Ronnie. Thank you for those words and for the continuing support from you and the John A. Hartford Foundation to the entire Hospital at Home community. The users group is sponsoring today's webinar. The users group web address and Twitter handle is there. We also have sponsored a technical assistance center that can be reached through our website. On the technical assistance center, you will find tape recordings, as well as slide decks for all of the webinars that we've have organized to help hospitals and other organizations start up their hospital at home programs. We've developed a number of resources that will be helpful to the community. And we sponsor a number of other events, to provide technical assistance to the community. I have hosted a number of those webinars as well as office hours. And one of the things, that I can tell you across all of these is that invariably a question comes up in the Q&A, perhaps more than one, on what happens after the public health emergency and what can we do to ensure that we maintain the payment models of some form, post PHE. And so next slide, please. We have done a number of these webinars, and the next one, that we hope to do will be one related to building and supporting your hospital at home program. But for today's webinar, we're going to be looking ahead and trying to see, what we can glean about what hospital at home looks like beyond the public health emergency. And for that, I am pleased to introduce our two speakers today, Ray Quintrero and Andrew McPherson from Healthsperian. Now, Healthsperian, we have partnered, the Hospital at Home Users Group has partnered with Healthsperian to help us, navigate a path forward in terms of, how we approach support for hospital at home beyond the public health emergency. Their work with us has been an extension of their work for many years, with the American Academy of Home Care Medicine. So I'm pleased, to introduce both of them to all of you and to have them host this discussion today. Ray and Andrew are managing partners, at Healthsperian, and they've had many decades of deep experience in healthcare, in policy, legislation, communications, as well as political experience. And we hope to parlay that experience to help the Hospital at Home Users Group navigate a path forward. So welcome, Ray and Andrew. I'm going to turn it over to you.
Great. Thank you so much, Al. And on behalf of the entire Healthsperian team, good afternoon to everybody, and thank you for your participation today. Also, thank you all for your participation in the Acute Hospital Care at Home waiver, and/or thank you for your interest in and support for hospital at home overall. Also, our appreciation, of course, to the Hospital at Home Users Group for inviting us to be a part of this conversation today, and of course to the Hartford Foundation, as well as the American Academy of Home Care Medicine and the American Hospital Association for their great support of the issue in order to continue these flexibilities and to move hospital at home forward for the future. We will continue to need great support from our participants. Andrew and I really couldn't be more excited to speak about this issue today at such an important and pivotal time as we're reshaping the healthcare system and starting to reimagine how to best meet patients where they want as well as where they need care. One thing that we think we should always do is talk about context. We really do believe that context matters. As we all know, COVID had turned our lives as well as the healthcare system upside down. We've all experienced it in so many different ways. We continue to experience it. Policymakers as well as stakeholders, they responded in order to address the public health emergency and continue to do so on a day-to-day basis. Today, they and we are also taking the learnings as well as we're seeking opportunities to do better for patients as well as the system beyond the PHE. And what we're doing is we're starting to think forward and think ahead, not only for another PHE, but how, again, to reimagine what the healthcare system should look like. The squares that you see on the screen and the associated work that's being done are all interconnected, which Andrew will address further. Andrew?
Thank you, Ray. In Washington, we tend to reflect and work on issues in silos. The prospects for drug pricing reforms, for coverage expansions, for post-acute payment and reforms, but that's not really how the Washington organism works, as we know. These issues are interconnected in the most complex of ways and are really driven not just by policy, but yes, of course, by politics as well. In just over 6 months, we've witnessed an extraordinary amount of activity on a whole number of major healthcare issues in Washington, of which hospital at home is a part. The new Biden administration came into office really focused on three main priorities: COVID-19, COVID-19, and COVID-19. They were able to put forward and pass a mammoth relief package, as we know, the American Rescue Plan. Yes, it was passed via reconciliation procedures without Republicans, but it does represent a monumental achievement to fight the COVID-19 pandemic in this country. No, the administration will not hit their July 4th targets for the number of vaccinations in this country, but the COVID relief package really played a significant role in curbing the worst of the pandemic. But simultaneously, the Biden administration and the Democratic Congress have been focused on a number of other issues that will impact the environment for hospital at home and its potential extension beyond the PHE. Things like vaccine distribution, the decision around the Affordable Care Act from the Supreme Court just last week. Policies and issues related to updating and changing and potentially improving the Affordable Care Act. A number of CMMI alternative payment models, even beyond hospital at home. Here and now, the focus is really on the Biden infrastructure proposal and whether that will include a number of healthcare policies along with it, like support for LTSS and the caregiver economy. This renewed drug pricing debate. We saw just last week that Chairman Wyden of the Senate Finance Committee put forward his principles for what addressing drug pricing should look like in this country. And of course, coverage expansions are always on the table. And the public option, while likely not moving this year, is going to get an extraordinary amount of attention. Well, the question is, what is the connection to our work at Hospital at Home? And what is really driving a lot of these discussions here in Washington? Well, I think it's important to note that the American public is demanding action on all of these issues. About 9 in 10 US adults say that they support allowing the federal government to negotiate with drug companies to get a lower price on prescription drugs. 92%, that's from the Kaiser Family Foundation. About 9 in 10 support expanding Medicare coverage to include things like hearing aids and dental and vision coverage. About 9 in 10 support placing a limit on how much seniors spend out of pocket on things like prescription drugs. And I think importantly, and by the way, this is bipartisan, all of these issues are bipartisan. I think about 8 in 10 say that they support expanding government health insurance coverage for lower income people. So all of these issues share an extraordinary amount of support from the American public. And that's really one of the major issues that's driving the debate today. Ray, I'll turn it back to you.
Thanks, Andrew. And on the next slide, with all of the issues that Andrew just touched on, it's important to note that there's so much happening on the policy as well as the political context. And it's important that we continue driving home the message of the importance of hospital at home. So let's level set and talk a little bit more about why we're here and where we go from here. We're going to move from a discussion about the hospital at home landscape to talking about Hill engagement and thinking about the current waivers and flexibilities and extensions that are necessary, and also talking more broadly about the opportunities and approaches that exist within the CMMI work that's being done and simultaneously being discussed. And then finally, we'll talk about the current evidence that exists, as well as the data that is still needed for hospital at home and the importance of being able to compile that, collect it as quickly as possible, but in a way in which we can deliver that up to Capitol Hill and up to other policymakers and regulators. And on the next slide, we're going to move toward the landscape, as we mentioned. Reimbursement challenges and flexibilities, as you see, hospital at home prior to the PHE, many would call anemic. Many would have called anemic, and it really was. And there was one main reason why that was the case. The main reason that was the case was because of reimbursement. There was not a reimbursement structure under Medicare that allowed for payment for the services to be provided in the home. And in addition to that, stakeholders and policymakers, they finally sprung into action when the PHE hit. At the start of the PHE, to ensure that there were mechanisms in place, that there were opportunities to care for patients where they should be cared for, where they could be cared for, should they choose to be treated in the home. In order to keep them out of harm's way, in order to keep them out of hospitals where they could potentially receive infections from COVID-19 patients, but to allow them to be treated and to be able to be cared for in an environment where they felt safe, where they felt comfortable, where their families felt safe and comfortable in being able to visit them and being able to see the care that they were being provided. And there was an acknowledgement suddenly that this care had existed in the past, and this wasn't a new concept, but this was a concept that was able to be put into action. It was in action prior to the PHE in some context, and it was going to be in context or in action during the PHE and would be valuable and would be successful. But in addition to that, stakeholders as well as policymakers pushed hard in order to ensure that not only Hospital Without Walls was put into place and those flexibilities, but also the Acute Hospital Care at Home waiver was put into place to address some of the issues that initially had overly burdensome and unnecessary requirements based on the type of care that was being provided in the home. For example, as you all know, and many of you experience firsthand, the 24-hour on-premises nursing requirement during the initial part of the Acute Hospital Care at Home waiver that was in place, because of an interpretation by CMS that existed for a condition of participation that was thought of well before Hospital Without Walls, well before Acute Hospital Care at Home, and without the consideration of hospital at home, but just about a traditional inpatient setting. And a more pragmatic approach was addressed and was moved forward by CMS in order to ensure that this type of care could be provided. We'll discuss later the growth as a result of the greater opportunities ahead. On the next slide.
Yeah, and I'll just jump in there, Ray, as well. That as we think back, COVID-19. If we go back one slide, please. COVID-19 represents just an incalculable loss in this country. And we're still all grieving in so many different ways, grieving the loss of employment, or grieving the loss of a loved one or family member. But it did allow for the opportunity to test a range of new models of care, including hospital at home, as we know. And as our firm and a number of others in the users group, really began to educate about the extent to which this model is being used and the evidence base that was available for its implementation. It's really been an extraordinary process that we've gone through together as a community representing hospital at home, both with the Congress and the administration. I think we've never been really better positioned to achieve success on this issue and ensure that we'll have a really structured reimbursement stream going into next year. Back to you, Ray.
Thanks, Andrew. So in terms of legislative strategy for a waiver extension, there is certainly an opportunity here. As we all know, once the PHE ends, the current flexibilities that exist, they all end as well. They will all end without congressional action. The Secretary does not have the authority as it exists today in order to extend the current waiver that exists, the Acute Hospital Care at Home waiver. So Congress has to intervene in order to do so. And it's therefore very important to educate members of Congress to ensure that they understand the full opportunity that exists so that they understand what waivers are in existence today. In conversations that we had early on, that we had in the fall, and that we've continued having, some members of Congress were not aware and are not aware of what exists today. And as we start talking and having a conversation with them, they now have a clear understanding of what hospital at home is, of what the waivers are, and what they're providing, and the type of patient care that's being provided in a safe manner, in a cost-effective manner, and in a manner that is in their backyards and is providing great care in their communities and should be continued. So there's really been a shift in the discussions in that there's much greater enthusiasm, there's much greater understanding, but there's also, as we saw during the Senate Finance Committee hearing on the PHE flexibilities, there's much greater support. There wasn't anybody that stood up in that hearing. There wasn't one senator that said, we don't support extending hospital at home flexibilities. We don't support extending those flexibilities that allow hospital at home to continue beyond the PHE. On the contrary, there were senators that said, we should extend these. Why not continue. Even the Chairman Wyden, at the end of the hearing said, this sounds like a good idea after Dr. DeSherry talked about the importance of extending these waivers beyond the PHE because of the type of care they provide, because of the choice that they're providing to patients, and because, again, we're reimagining the healthcare system not as it existed before the PHE, even though hospital at home did exist before the PHE, but we're thinking about the healthcare system in a more patient-centered approach and in a way that we can address health equity issues, in a way that we can reach more patients, provide additional access, and provide care in a way that's comfortable, that's convenient, and again, still making sure that it's safe as well as effective for the patient. Next slide.
Members of Congress and their staff have just an extraordinary amount of issues that they're focused on a daily basis. And that goes even for the committee staff on the Senate Finance Committee, which would have jurisdiction over the Social Security Act, the Ways and Means Committee, even the staffers that are solely focused on healthcare at the Congress, just have an extraordinary amount of different issues that they're dealing with on a daily basis. So we had a pretty significant hill to climb together as a community in order to educate committee staff, educate members of Congress and their healthcare advisors. But I'm very proud to say, as Ray mentioned, that after it's been over a year that we've really been educating a number of offices on the Hill, we're really starting to get traction. I think that Hill offices are really understanding not just what the model is, not just that it's been around for so long, not just that it's working and expanding, but that there's a really important opportunity here to extend this sustainable reimbursement beyond the public health emergency.
So this is a great visual, and even after our slides were submitted, there has actually been an update in terms of the number of participants that have actually received the waiver under acute hospital care at home. So this shows the trajectory going back to January and going up to just yesterday when the numbers were most recently updated. We've seen an increase from 74 to 142 hospitals that have been approved for the waiver, from 30 to 68 systems that have been approved, and from 22 to 32 states that have been approved. So this trajectory has continued to grow. However, one thing that's important to keep in mind here is that because of the investment, and those of you that have invested in hospital at home and have invested in developing these programs, we applaud you for it, because there's an understanding that this investment is one that goes with uncertainty. There's uncertainty as to how long you can continue providing this care in the home and actually receive reimbursement under Medicare. Because as we've mentioned, once the PHE ends, the reimbursement will go away without congressional action. So we also know that there are some that will sit on the sidelines until there is more certainty, there is greater certainty prior to them making this type of investment in hospital at home. So this trajectory will likely level off until there is some sort of something in place where they know that there will be a consistent stream of funding and there will not be a cliff to where the funding will suddenly end and their investment will go away, but also that they won't be able to provide that care in their communities. The care in their communities that patients are asking for. As Andrew mentioned in one of the early slides, the individuals are starting to ask for these types of policies to be put in place. They're asking for hospital at home care, and it's important for this to go ahead and continue. Next slide.
I think it's sort of healthcare policy 101, that once the Congress passes something or an administration moves forward on a new benefit or a new policy, and you've allowed patients and Medicare beneficiaries and others to access it, it's very hard to take it away. So our hope is that the momentum that you all have created and that the Congress and the administration is supporting you on will continue, and that we'll continue to see sort of this explosive growth, and that patients will continue to demand this model of care.
Absolutely. And this slide is really just illustrative of the number of states that have waivers approved. So those that are shaded in blue, those are the 32 states that already have waivers approved. Importantly, again, because of the investment and uncertainty, there's still opportunity here. There's still opportunity. You see all of the white states. Those states could still be shaded in blue eventually and have the waiver approved at some point. But even those states that are blue currently, it doesn't necessarily mean that the participants in those states cover the entire state. So there may be portions of the state that do not have hospital at home programs up and running. There may be communities that are not impacted by hospital at home yet, again, because of the uncertainty, and those hospitals that have not yet applied for the waiver, but would apply for the waiver should there be more certainty about the future of the acute care at home and hospital at home overall. And I'll hand it over to Andrew.
Thank you. CMMI, boy, CMMI has been around for, obviously established by the Affordable Care Act, now dozens of models that have been considered are being implemented. We're at a critically important moment for CMMI in its work. And that moment could not be more important, as we all know, for hospital at home. Yes, hospital at home is currently being, the current waivers allow for a bundled payment of acute inpatient care in the home. We're really looking for a hospital at home payment model that would benefit from a value-based 30-day bundled payment approach. Now, I want to say thank you to the Hospital at Home Users Group and many of the folks that are on the webinar today for your education and your work to really, to really advocate and have CMMI better understand this critically important model. The goal I think that we collectively share is that there's an alternative payment model ultimately through CMMI that's an effective pathway to the future of providing hospital at home services to the Medicare population. I think we can all share that goal collectively. The goal of the model will really be to improve patient care, to lower costs, and better align payment systems to promote patient-centered care. I can't think of a more ideal model to really hit the triple aim that this administration continues to be supportive of. A successful CMMI demonstration would give providers a care and, most importantly, payment pathway to adopt hospital at home services within their practices.
And Andrew, we should briefly add that these two approaches, the legislative approach and as well as the opportunities with CMMI, are not mutually exclusive in the sense that the approach on the legislative front, as you know, and as we've discussed, will focus on the current waiver that exists today and will ensure that there isn't a cliff and that it can continue, and that there's an opportunity and that there's time for CMMI to develop a model to move toward that 30-day value-based payment bundle. That is not what the current waiver is today, but that is what CMMI, what CMS can ultimately build. But we also, again, know that in order to build new payment models within CMS and CMMI, that does take an extensive period of time, no matter how quickly they work, and even if it's top priority. And we've had very positive conversations and good signs that this is something that's important to the leaders. However, in the interim, at minimum, there needs to be a continuation of the current flexibilities. So these are parallel approaches that do align with one another and support one another. And Congress and the administration can work collaboratively to ensure that this opportunity is fully realized in the short term as well as the long term overall. So that's important for us to mention.
I think it's really important to also think about where CMMI is today in their thinking. We have a new administration, we have new leadership at CMS, at HHS, really across the department in all agencies. And this is a really important moment because the administration spent 3 or 4 months really getting those leaders in place. And the Biden administration really has tapped some of the best experts in this country on a whole range of issues. And I would put Director Liz Fowler really at the top of that list. Director Fowler, many of us know very well and have worked with for many, many years. People considered her sort of in many ways, the COO, if you will, the chief of staff who ran the development of the Affordable Care Act under her then boss, Chairman Max Baucus from Montana, the chairman of the Finance Committee in 2009, 2010. She has since spent time at the Commonwealth Fund and other places. Nobody understands models better and delivery system issues better than Director Fowler. So we're very optimistic about her leadership. But I think it's important to note that they've made a number of decisions to really rethink and potentially change the direction of CMMI. So it sort of begs the question of how does hospital at home fit into the new thinking of this administration and their priorities. Well, number one, there is a commitment from this administration to ensure that all of the models and all of the characteristics of those models are truly patient-centric. And yes, we've been saying this for a long time. How long have we been saying patient-centered or person-centered? Well, this administration is going to leave their own mark on what that definition is. So very important that we're always communicating with the administration and CMMI about how person-centered this model truly is. Second, but I think equally important, is the issue of health equity. This administration has made it very clear that, and the director, Fowler, even as recently as last week, has made it very clear that as they rethink a range of models at CMMI and their new direction going forward, that they are doubling and tripling down on their commitment to health equity and to inclusion of communities of color, of rural regions, as well as beneficiaries who are homebound and or have multiple chronic conditions. So very important that we communicate, that you communicate, and we communicate collectively as a group with this administration, with CMMI, about how hospital at home achieves these two very, very important goals. So the final portion of our presentation today, we want to talk about the growing evidence base and data needs for hospital at home. I think it's, as we look back over the, frankly, many decades now, since the mid to late 90s, that this model has been available and has been understood and researched and looked at. And I know this is hard maybe for someone on the call to hear today, but we need to continue to educate about not just the model itself, but the evidence base for how it works to protect and serve patients in the home setting. Next slide. I think back to even just 5 or 6 years ago, the PTAC process, the Physician-Focused Technical Advisory Committee developed by MACRA, the legislation MACRA, and that process that included 2 proposals related to hospital at home. Very important for laying the groundwork and the evidence for where we are today, but we still have a long way to go to make sure we're educating about the fact that this model works. So of course, the concept of hospital care in the home is not new. Multiple studies of hospital at home models have demonstrated improved outcomes, reduced length of stay, reduced patient readmissions and mortality rates, lower rate of patient delirium and sedentariness, increased patient satisfaction, and lower rate of patients being referred to a skilled nursing facility after the care episode. So I know we know this, but it's very important to be communicating this information to the Congress and to the Biden administration. Studies, of course, have also found that costs for hospital services in the home were 19 to 30% lower than traditional inpatient care. But overall, the hospital at home model advances the cost-effective, high-quality care delivery of acute inpatient services to patients in their home settings and is doing so today for Medicare beneficiaries across the country. So very important that we continue to communicate this evidence base as we move forward as a community. Next.
And all of these items resonate very nicely with Hill offices. They resonate, of course, with CMS, which is why CMS was willing to move forward the waivers. And the Hill offices, they ask us time and time again, what data is out there? And we're able to share previous data from studies that have been done in the past, and as well as other studies on hospital at home. But they're also looking for any data that exists from the PHE and any data that we can share and anything that speaks to this, because they're very interested in seeing something that's tangible. But even being able to speak to the fact that the opportunity that this presents based on previous data and the opportunity that it presents beyond the PHE also speaks volumes to them. So coupling all of that is also very valuable. And then thinking about this in a value-based payment model, as Andrew was mentioning, similar to the models that were proposed to PTAC by both Mount Sinai and the Marshfield Clinic, which were percentages of a DRG and focused on, they were slightly different, but they were also based on a different number of DRGs and had slightly different approaches in terms of the bundle. But nonetheless, ultimately, this would look at how you can present value to a patient and be able to advance a model that would be appropriate as well as would be quality centric, as well as with providing safety and ultimately savings to the system, but also improving care overall.
So again, really important that we're communicating that hospital at home is an opportunity to use data to show how the program improves patient satisfaction, lowers costs, and addresses health equity. I think also important as we think about the public health emergency, as we think about really the growth of and the expansion of the model over the past year, one of the arguments that we need to make and are making and need to continue to make is that we need to also look at how across the country in different areas of the country, be it rural or urban, how the model is being used, the data that we're getting from the model in a non-pandemic environment. And I think that's a very compelling argument to make for the continuation of the model going forward. So of course, data on improved patient satisfaction, on fewer errors in the transitions of the care processes, and lower costs is very robust. We know this. Hospital at home, participating hospitals and health systems, really can use the data to support the case for CMMI to develop an alternative payment model going forward. And we know that the hospital at home users group has been doing that for quite some time now. So hospitals and health systems can also use their population and outcomes data to demonstrate how the program has improved the quality of care for costs for patients with complex care needs. I think those that have multiple chronic conditions, trouble with activities of daily living, are facing serious illness, this is going to be a real focus for this administration going forward. And hospital at home, of course, directly supports their needs and is of particular interest to CMMI and its leadership. So just in conclusion, we want to talk about sort of the timelines. What are our markers for success as a community going forward? And no consultant in Washington should ever offer predictions for the future, but we're going to offer a few with you today. Advocacy on Capitol Hill and with senior Biden administration officials continues, again, with a focus on data and the need for a feasible extension. I think we've been very successful so far at educating bipartisan champions and cultivating support for the model and getting them invested in its continuation. Stakeholders, it's really important that what we consider sort of the fourth branch of government, the stakeholder community, AKA you and others in Washington, coalesce around a shared strategy to ensure the extension of a sustainable reimbursement mechanism for hospital at home. Again, health policy 101, once you give patients, AKA constituents, members of Congress's constituents, something that they want, something that they demand, it's very hard to take that away. So I think that is something that is working in our favor. Also importantly, Congress works very well with the concept of cliffs. They work against deadlines. They very rarely pass major pieces of legislation with respect to healthcare and tax and otherwise that isn't up against a deadline. Well, we've got a pretty significant deadline at the end of this year, and that's the public health emergency no longer being in effect, which obviously would remove the potential for continued reimbursement for the model. So that actually is working in our favor, we would argue, that we're working against a deadline. That cliff, the more of you that participate in this model, that are able to reimburse for this, and the growth that we see in this model, that lends itself to a lot of momentum that the Congress is particularly interested in related to this cliff. Of course, while it's unclear, that major healthcare provisions will be included in this current infrastructure package, whether it be telehealth, hospital home extensions, or otherwise. I think there's a very good chance, and we would argue that there's a very good chance that by the fall or the end of the year, we will get an extension of some sort. But we have a lot of work to do between now and then. Simultaneously, the work with CMMI proceeds apace. And that engagement with CMMI leaders, with the leaders of the different teams at CMMI, with you all, is critically important in order to ensure that we have a long-term, sustainable, value-based payment available for hospital at home. So Ray, I'll turn it to you for some concluding comments as well.
Thank you, Andrew. And I know we want to leave time for questions, and we're nearly at time. The only thing I would say in conclusion is that, as Andrew mentioned, coming to or coalescing around a shared strategy is certainly important, and having a lot of voices that are delivering a similar message and an aligned message will amplify the importance of this work and the importance of an extension, the importance of building a model. But nonetheless, those of you that have government relations teams, certainly that would be very helpful. And we're happy to connect with any of you at any point to have discussions about how to advance that message. But importantly, it's important to educate members of Congress as well as their staffs about what we're doing, what you're doing out in the field, because that's what they want to hear. They want to hear the stories. They want to hear how you're treating patients and the importance of being able to continue treating patients in their home. So with that, we'll conclude and hand it over to Al for questions.
Thank you, Ray and Andrew. We topped out at about 200 participants today, and of course, there will be many more who will listen to the tape recording afterwards. There were a number of questions, and I'm going to start out with where you left us off in terms of, of a strategy going forward. One of the questions, that was chatted in by my colleague Bruce Leff was actually, how can the users group help here? And what is the strategy that we can coalesce around as a users group, and how can we pull together the resources and the efforts, of the various users group members, in probably, red states and blue states, across this country?
Great question, Al. And I think, as we started alluding to on the final slides, is the users group members and those that are participating in the waiver, any data that you can provide on patient experience, any data you can provide on quality, certainly anything on cost savings would be valuable. And anything that you can share with us that we can then share with Capitol Hill offices, especially those that sit on Senate Finance, Ways and Means, would certainly be helpful, as well as leadership offices, to be able to show them the additional value that the waivers are bringing, so that they have great impetus to go ahead and continue those. And it's, again, continuing that education process so that we are never out of sight or out of their mind.
Yeah, I would just, Al, add that there's no one healthcare system, there's no one company, there's no one academic leader, or certainly not one lobbyist who's going to be able to get this across the finish line and ensure that there's sustainable reimbursement for hospital at home going forward. It's going to take all of our collective efforts, and we're very much looking forward to working with the users group, along with many of the innovative companies and academic leaders in this space, to ensure that we do so. It's going to take all of us. It's going to be a group effort, and we're very much looking forward to working with you to coordinate those efforts.
Because many of us, are parts of hospitals and health systems. And in our case, and in the case of many of our colleagues, we've heard from our government affairs staff at our hospitals and health systems, willing and, anxious to help. And we would welcome, taking a cue from Healthsperian in terms of what we ought to ask them to do.
Yeah, and I'll say, Al, just to get a little bit more specific, and we'll certainly be having strategy meetings with the leadership of the users group and many others. It's really important that we coalesce around shared language, around legislative language, to get this over the finish line, to get legislative language introduced in the form of a bill that then we all support collectively once that's public moving forward. And I know that we're in the midst of developing that as we speak, but we'll absolutely be sharing that with this group once we have bipartisan, bicameral support for this legislation to extend the reimbursement going forward.
Thank you. There have been a number of questions about what happens when the PHE ends, and whether there's likely to be a hiatus in terms of being able to do this in traditional Medicare. One of the participants, was interested in the model and was wondering, whether they should actually jump in now or not, given, that the PHE might be ending. You know, I was wondering if the two of you could reflect a little bit on whether there'd be hiatus, you know, and what do we tell people who may be interested in jumping in at this point?
So Congress at the moment is considering all flexibilities. They're thinking about telehealth, they're thinking about hospital at home, any flexibilities that were put into place as a result of the PHE to ensure that there isn't any hiatus, unless there are flexibilities that they believe should not be continued. And the hope is that there will not be a pause in any of the flexibilities that they want to continue. And these would again be a part of a package that would move this year in order to ensure that there is no cliff, so that it doesn't all end and then have to restart. Because once you end something and try to restart, the administrative portion of that makes it difficult not only for the participants, all of the hospitals, but also on the regulatory side in order to do so. So the work that we continue to be engaged in and invite everybody to be a part of as well is to ensure that there is not a stop and that this can continue seamlessly. And there's already been a discussion from the administration that even at the end of the PHE, those that would be expiring, there would be 60 days, or there would be a notice in terms of the length of time that those could continue. But our hope is that we would not be in that bucket. Our bucket would be those that are continuing, and that's the work that we will continue to do.
Yeah, I think that's exactly right. Just to add a little bit more color, Al, doing nothing is a policy choice with very serious consequences, not just for all of you who are implementing this model, and many of the academic leaders, of course, who have led this model for so many years, but for the patients that you serve. And that's the message that we need to be continuing to deliver on Capitol Hill, that doing nothing is a very challenging policy choice on their part. That being said, while we're optimistic that reimbursement will continue and that there will not, as Ray was saying, there will not be a cliff, it's the Congress, again, they act against deadlines. And they traditionally are not, they're not very good at giving you a lot of lead time in the provider community with respect to future reimbursement. So it's possible that there will be, that the next, as we get into the fall, there will be some, we may get sort of nervous as a community about what they decide to do, and that it may get, into Q3 or early parts of Q4. But that's the work that we have to do together, that we're doing with you all, the users group, Healthsperian is. And our hope is that we'll learn very soon about whether that reimbursement will be continuing beyond into 2022 without a cliff.
You guys talk about, about the cliff and the need for congressional action. Let me just have you flesh out to some extent, the legislative and the CMMI track a little bit, for us. Ray, I think, that you said, and I hadn't heard you say this quite as starkly as you had this time, that the secretary does not have the authority, to extend this, and continue this beyond the PHE. In which case, does that mean that we really do need to have a CMMI path? And how does the CMMI path, how is that viable without congressional action if the secretary does not have authority? If you could just flesh that out a little bit.
Sure. To start out, so the secretary under the PHE declaration is granted certain authorities that only exist during the PHE. One of which is to provide the types of waivers and extensions that are necessary in order to put into place hospital without walls, to put into place the flexibilities for the acute hospital care at home waiver, but those only exist during the PHE. So Congress would either need to act in order to continue these or give the secretary some sort of authority outside of the PHE realm. It's more likely that Congress would want to act in order to extend the flexibilities on their own, based upon the flexibilities that they believe should exist. And again, it would be their preference. But with that said, fleshing out and thinking about the importance, what also is necessary here with any sort of policy that Congress is advancing that has regulatory implications, as this does, and important regulatory implications, is that we also want CMS and CMMI to be supportive. And we want them to feel as if these make sense, that this has worked well, and that it should continue. And up until now, we have not received pushback, either on the Hill to say that this doesn't make sense, it doesn't work, it is a bad policy. As well, we haven't heard that from CMS. It doesn't mean that there may not be some that may feel that way and are not vocal about it. But importantly, those that are vocal and those that are having discussions at this point about what should be extended, what can be extended, they are not putting that into a negative place. They're being very positive at this point. And again, it's our continued role, our collectively continued role, to make sure that, or to help them remain positive and to address any issues that they may have. If they do believe that this could be problematic because of X, Y, or Z, that's where we provide them the data to show them that this could be helpful and to work with them in that regard. So again, that's why it is important for Congress to act for purpose of the waiver, but also important for us to have the support of the regulators and the administration overall, but then also to look at a broader strategy that would ensure that the opportunities can continue beyond what exists in today's waiver.
Speaking of, of the legislative strategy, one of our questions here is whether a consideration has been given to workforce issues if hospital at home is extended, in terms of training of residents and of nurses in hospital at home care.
So at this point, for purpose of the current waiver, obviously it takes a collective in order to be able to provide this type of care. It takes a team, and as with any sort of care that's being provided, there is an importance of training and education, and whether it's through continuing medical education or just in general, making sure that we do have a trained workforce that is aware of the type of care and is interested in going into the home. So part of it's an awareness issue, just as there's an awareness issue that exists with home-based primary care, for example, but also an encouragement to ensure that those that are going through school have an understanding that there is an importance of going into the home and why it's good for patients, it's good for the system. So similar education that can occur with members of Congress and regulators is similar education that can also occur with those that are going through the system to become healthcare professionals and that can be providing this type of care. One quick point, Al, that just popped up in the chat was regarding the public health emergency, and it was regarding the president being able to extend it. Now, certainly, we've seen many extensions. We've seen extensions since January of 2020. Every 90 days, the president can extend it. We're not saying that it's concluding in July, because the current PHE does conclude in July. We do anticipate that it will continue through the remainder of the year. But what we're discussing is once the PHE does end, after those 90-day extensions do finally end, which there could be 2 more, there could be 3 more. Again, that's uncertainty in terms of how many more there will be. What we're seeking is complete certainty that we no longer have to live in 90-day increments.
Yeah, I was just going to make that point, Ray. I think if I were a health system or an individual hospital or one of the companies that's partnering with a number of these hospitals and was basing my revenue stream and the decisions I was making for this patient population and this model on 90-day decisions by the White House or the Secretary of HHS, boy, that's terrifying to me. And so our goal is to learn from the reimbursement that's been allowable for the past over a year now, but really get into a more sustainable, is what we've been saying throughout the presentation, and longer term reimbursement pathway. That's really the ultimate goal here.
And that is, the concern in many of the questions have been put up on the chat. in Q&A today. Do I jump in now in terms of starting a program? Will there be an opportunity later, or will this only be available to programs that will be grandfathered in? And how will new programs, be treated going forward? But we are at the top of the hour, so let me take this opportunity to thank, Ray and Andrew, for their presentation and for their future work with the Hospital at Home Users Group as we try to navigate a path forward beyond the PHE. And again, thanks to Ronnie and the Johnny Hartford Foundation for their enduring support, of hospital at home work, for 2 decades now. Gabby has put up a final slide here, with information on where you can find information on the users group, as well as the technical assistance that we provide, as well as some of the resources that we've made available recently. At the end of this webinar, a survey will pop up, and we ask you to, respond to the survey. And particularly if you have thoughts in terms of future webinars that we ought to be trying to organize, please put them on the chat. We do look at that chat, and that does inform the content of future webinars. So thank you to all of you and to our participants for their many questions. We hope to see you again in a future webinar.
And one final note, the annual meeting of the Hospital Home Users Group will take place on October 28th, 2021. Keep check your inboxes for information about the meeting, and indeed, if you're interested in submitting a session or a poster for a meeting, the deadline is July 31st, and you see the email, the URL for that submission piece there. Again, thanks everyone.